I think
Yep.
Dr. Grube will be on Zoom.
Yep. I just share my screen with you. Can you see my screen?
No, no,
Not
not
yet.
it.
You got it?
Yeah, yeah, we can see.
Okay,
You can go ahead now.
perfect. So topic of my talk is cerebral protection with a subtitle, Do Data Allow for its routine use? Again, I would like to continue with my financial disclosure. And I would like to start with a disclaimer. In my view, should protection be standard of care even after Protect TAVR? I believe yes and should. And I think I would try to make my point during the following minutes. The arguments that we hear is stroke in TAVR is declining with every generation of TAVR systems. In high volume centers or experienced operators, stroke has almost disappeared. Stroke is more prevalent in high-risk patients, as low-risk patients will have less debris. Cerebral protection is complicated to use and adds time and risk to my procedure. There's no evidence that it actually reduces stroke with two so-called negative trials. The only available device, Sentinel, doesn't cover all four arteries supplying blood to the brain. And of course, a very important one, it is costing too much. However, if we look at everyday life, this is an interesting audience response regarding cerebral protection during an ACC meeting. What is the biggest concern for your patients undergoing TAVR? 70% answered suffering a stroke. Is cerebral protection necessary during TAVR? 80% said yes in selected patients. So even though we moved along with more modern devices, stroke is still an issue, and rightfully so. We all know the known consequences of cerebral injury. There's an increased risk of later CVAs, cognitive impairment, and vascular dementia. One of the very important aspects is that obviously we have obvious and apparent stroke or injury signs, which is obvious to everyone. But then comes the more sophisticated, quiet, subtle, silent, and even subclinical. And the percentage you can see is still significant, 15 to 20%, and subclinical, 68 to 84%. So it is not everything that we see that we can say this is very obvious and apparent. It is also something that we have to deal with if we look at this silent group. The effects of stroke after TAVR are very well known. Mortality increased, as shown here on the right side, with stroke 16.7 versus 3.7. Decreased rates of discharge to home, increased rates of 30-day readmission, and higher index hospitalization cost. I think this is undoubtedly true. Effects of stroke are significant. Unfortunately, stroke after TAVR remains very difficult to predict. That is a fundamental issue, because if we were to know and we could predict the stroke, then we could use protection in those patients. And also, stroke is a devastating complication and not comparable with other, even minor or even larger complications. The only device that's on the market and approved is this one. There are many more in the pipeline waiting for approval. The Sentinel protection system, and that is something that we should be looking at it very carefully. The Sentinel IDE trial in 260 patients, randomized 2-to-1 to TAVR, in 99% of the patients, almost all patients, were capturing debris with various particle sizes as shown here. Very important also, the device was very, very safe, no increase in 30-day MACE, and there was a reduced stroke 72 hours post-TAVR in a post-hoc analysis, 8.2 versus 3.0. Those are single-center studies evaluating the effect of Sentinel on stroke after TAVR. And you can see here Germany, America, and the Netherlands. In yellow, unprotected, and in gray, protected patients. Across the board, internationally, in those centers, Sentinel was effective in effects on stroke. The problem came here. Even if we look at NIS study, highly significant, 36,000 patients with and without SEP, significant. Here, at the TVT, and the TVT registry, looking at instrumental variable, no significance. And if we look at propensity score, barely significant. And then in the German national database, there was no effect. So that was the problem that we're facing. In a summary, at the TVT registry, the author concluded no stroke reduction in a primary analysis, although secondary analyses suggest a modest benefit that is possible. The findings support clinical equipoise and provide a strong rationale for ongoing large-scale randomized trial to test whether protection provide meaningful clinical benefit for those patients undergoing TAVR. And those are the two trials, Protect the TAVR and Protect TAVI at the British Heart Foundation. We know Protect the TAVR is completed with close to 3,000 patients. And the BHF, we're waiting with close to 8,000 patients randomized to TAVR with or without Sentinel. Primary endpoint is the same, stroke at 72 hours or discharge. And all patients undergo questionnaire to assess stroke-free status with subsequent stroke physician review. However, there are important differences between those two trials. There's a different definition of stroke, and there's different method of primary outcome ascertainment, and the data are 12-month follow-up. Brief review of the protection device published in New England Journals. The objective was to study whether clinical stroke and transient TAVR is reduced with SEP. Prospective post-market multi-center randomized controlled trial in 51 centers in North America, Europe, and Australia. This is the study flow, study design, 1,500 TAVR only, and 1,500 TAVR with SEP. Neurological examination at baseline and discharge or 72 hours after TAVR. Statistical methods we can skip, I believe. That is not so important for the topic here. Baseline demographics are very balanced between control and SEP, except for female gender. But looking at surgical risk and native calcification severity, basically well balanced. Also, procedural characteristics were well balanced between the two groups: anesthesia, valve anatomy, the prosthetic valve type, and pre and post dilatation views. And that's the primary endpoint: all stroke at 72 hours or discharge. There was in blue non-disabling stroke, and in yellow disabling stroke. All over the in a total, there was a 21% relative risk reduction in all stroke through 72 hours. If we take the disabling stroke at 72 post-TAVR, then it becomes significant. 60% relative risk reduction in disabling stroke through 72 hours in patients that have been used protection with the Sentinel. Details of the disabling stroke, because this is fundamentally important. The majority was ischemic. Only one patient in the control and one in the SEP group was hemorrhagic. If we look at the 4 patients that had disabling stroke in the SEP-treated patients, a little bit more detail, then we can see here ischemic stroke with complicated TAVR, valve embolization, CPR, second valve place. So a lot of procedural issues during that particular TAVR deployment. Stroke symptoms apparent 2 hours post-TAVR. Then here, ischemic, uncomplicated TAVR, clinical symptoms consistent with stroke, but lesion localization uncertain, and only one uncomplicated TAVR with stroke in the left MCA territory, which was a protected vessel. So if we look in more detail, then we can say that the 4 patients that unfortunately had a stroke and protected were just not so uncomplicated as we might think. Obviously, clinical outcomes in patients with stroke are obvious. Mortality, as we said, discharge to home with no services in favor of patients protected, and higher intensity care needed with protection. So everything speaks for protecting the brain. Interesting, in the subgroup analysis, there were geographical differences between US and OUS. In US, the patient group was doing SEP that is better. In OUS regions, the control was better. We have to see why that is the case, but I think we know right now why potentially that's the case. In conclusion, the use of the sentinel SEP was feasible in the majority of patients with no major complications. Use of SEP did not reduce overall per-procedural injury, control, and SEP. The use of SEP, however, reduced disabling stroke in the control 1.3, SEP 0.5, especially ischemic strokes. No specific subgroups were identified with strongly favored SEP used for all stroke reduction. There were, however, limitations to the study, as with most of the studies. Trial design was very practical in order to facilitate enrollment and data collection. As a consequence, the study was restricted to a small number of endpoints with only short-term follow-up. Neurological professionals were not blinded to a patient's clinical course and hospital record, and the study was not powered to detect a treatment difference for disabling stroke. Now, let me finish with a few final remarks. Probably, and unfortunately, as far as I'm concerned, this study will not convince the non-users to use SEP despite reduction of disabling strokes. The users will continue to use SEP as they've done before. Also, nothing has changed. The cause of procedural TAVR-related stroke ischemic is debris, as shown here. And remember, in 99% of the patients, debris was found in the baskets. Also, nothing has changed with the sources of embolic protection: shaggy aorta and manipulation of the degenerative aortic valve, as seen in the 2 cases that were protected and had a stroke. Also, subclinical lesions after TAVR, the impact of those subclinical lesions and lesion volume on long-term cognitive outcomes in TAVR population is still unknown, but brain lesions, obvious or not, are not benign and need a follow-up. Also, the advisory panel strongly supports FDA granting approval. The FDA panel did not approve Sentinel based on statistics or efficacy, but rather on common sense, namely removal of debris after TAVR procedure. Very unique, as the panel decided this. So let me summarize the case for embolic protection: carotid stent experience, MRI abnormalities, silent infarcts are not benign. Studies have demonstrated that embolic protection devices reduce MRI abnormalities after TAVR. Potential for clinical benefit beyond stroke with cognitive improvement. If we can prevent embolic events, why not doing so? The case against embolic protection, as I said, conflicting data of small studies and registries, and of course, cost. And I'd like to use this slide from Sushil in a previous presentation. When should we use protection during TAVR? Well, look at predictors: advanced age, carotid stenosis, and prior stroke or TIA. And I think it's fair to say, if we do not use it in all patients, we should at least use it in selective SEPs in selective patients until further studies are coming out. Bicuspids, valve and valve, highly calcified valve aorta, and history of stroke. In summary, Stroke remains an issue in real-world registries and clinical trials with contemporary devices. Stroke has devastating consequences, including high risk of mortality and disability. Patients undergoing TAVR fear the risk of stroke over the risk of death. And cerebral embolic protection should be used in every eligible, anatomy permitting, TAVR case. With that, I would like to thank you for your attention. And again, thank you for having me.
Thank you, Dr. Grube, for a nice talk. In India, Sentinel is available for more than a year, but use is very limited. The reasons, as you have already told, mostly it is because of cost and lack of, because of the two negative trial that has come in. But I think you have a point. It to be used in patients who have heavily calcified valve, bicuspid aortic valve, and patients with carotid artery disease and peripheral artery disease.
Yes,
I don't know
at
what is
least.
the use in USA. Can I ask Dr. Ramesh, what about the protection device?
Yeah,
Yeah,
go ahead. Go
Eberhard,
ahead.
excellent talk, Eberhard. I think really you touched base on all the benefits of Sentinel, and also looking forward for other devices that are going to come in the future that probably could offer better protection than just protecting the carotids. You know, see here we are leaving the vertebrals still. So, but that said, in our site, I was just telling Anand Rao earlier that our site used to be 100%, now at about 60%. And as Eberhard said, selected use of CEP in patients, the bicuspids, valve-in-valve, calcium score more than 2,000. Obviously, much younger patients get, all young patients get valve-in-valves. And but that said, why is it 60%? Is because one of the person, my colleague, caused a carotid dissection trying to get the disc into the left side, left carotid. So then now he pulled back saying that, oh my God, I caused a stroke with Sentinel device. But obviously, you know, as we advance and we use it more often, we get better at it. So I think we should try to do it in 100% of the people, is my opinion. Yeah.
Thank you, Dr. Grube, and we move on.
Okay.
Next speaker. Thank you, Dr. Grube.
Thank you. Yeah, thank you very much.
Thank you. Thank you.